I'm a sports physio and one of the owners of the practice here. Thank you for coming along. This is about the third one of these we've done this year, and we're going to basically be talking about hip and knee osteoarthritis. Can I get a show of hands who's got hip OA? Yeah? Yep. Hip arthritis? Yep. Yep. And knee arthritis? Yeah. Okay. Alrighty. Now this is really just an open session as well. So if you've got any questions, please fire away. I think the best thing about these talks is it gives you a chance to ask any questions to us and really kind of nut out some of the things about osteoarthritis. All right. Now, we're going to be specifically talking about a program called GLA, which started in Denmark. It stands for Good Life with Arthritis Denmark. And we just need to, as part of this talk, acknowledge that that program came from there and then from Canada as well. And basically, the GLAD Australia program is 2 education sessions about osteoarthritis, and then a program of prescribed exercises to help with that, and which I'll explain. And basically, the objectives of today's talk are we're going to give you guys a better understanding of osteoarthritis. And this talk today is basically about what is OA, what are some of the risk factors, why people get OA, some of the symptoms, and also some of the treatments. And there's a lot of treatments out there for osteoarthritis, and some have got good evidence, little evidence, no evidence. And some of the ones that are being spruiked have very little evidence, and some of the other ones that are actually better, but don't hear of as much, have the most evidence. I'm just going to, sorry, I just want to. Alrighty. And this basically will result in less pain and a better quality of life, which is what this is all about. Okay? So that's just the an outline. So first session, what is osteoarthritis? What are the risk factors? Symptoms of osteoarthritis and treatment summary. In the second session, which we're doing on Monday, that's really one where I think it's a really important one because we actually teach you how to self-manage your arthritis. Okay, and I can guarantee everyone in this room has been managing their arthritis and managing their exercise incorrectly. Okay, because the information you've been getting is not correct. So that's what the point of this talk is about, is to basically get you guys exercising again. Okay, without the fear that the exercise is going to make your arthritis worse, make your pain worse. Okay. All right. So what is osteoarthritis? So osteoarthritis is a disease that affects the whole joint. Okay, so it's basically a disease that affects the articular cartilage or the lining of joints, and it's most common in weight-bearing joints, so hips, knees, spines, ankles, and previously, and the most common reason for not being active as people age is osteoarthritis. So it causes pain. When you're in pain, you don't want to move, you're scared of moving, and your health deteriorates because of that. Okay, so as I said, it is one of the big kind of social health issues facing an aging population. And it doesn't even have to be an aging population. There's plenty of people in their 30s and 40s that have osteoarthritis, and so we can't just consider it a disease of the elderly. And we're sort of moving away from calling it a wear and tear disease. It's sort of naming it joint dysfunction. So it's a dysfunction of the joint. Okay. It's more common than high blood pressure and diabetes, and it's the most common lifestyle disease in people older than 65 years of age. The knee and hip are the most common, with 30% of people aged 50 and above report hip and knee pain, and 5% of people between 35 and 55 show osteoarthritis on an X-ray. And there's basically the percentage of osteoarthritis as we get into later life. So you can see, when you're sort of getting into your 60s and 70s, particularly knee arthritis is, more than 1 in 2 people in the population are going to have it. It's that common. Hand is worse, yeah. So again, yeah, we're not going to talk about hands today, but it's very, very, very common. Yes, yeah, yes. All right, so this is a really important slide because this is going to be the start of getting you guys to think a bit differently about the way you move. So articular cartilage, this is what is affected in osteoarthritis. So it's the smooth lining over a joint. It absorbs shock and distributes load, okay? It's avascular, so it has no blood supply or nerve supply. And the most important thing there is that it is nourished through moving and taking weight through the joint. Okay, so if you stop exercising, what happens to your cartilage? It loses all its nutrition. Okay, so by not exercising, you're actually accelerating what got you there in the first place. So, if you remember only 1 or 2 things from this lecture, that would be the first one. So joints need weight and they need movement to lubricate themselves. You know what it's like if you don't move, you stiffen up everywhere. And that's just because your articular cartilage and your synovial fluid is not getting nourished and replenished, and you stiffen up because of it. So that's a really important take-home message. And this is basically a healthy knee joint. So you've got obviously the bone, the cartilage surrounding it, and then you've got all this stuff called synovial fluid, all right, which basically sits in the joint there. And then you've got, surrounding that, you've got basically an articular capsule, okay? So it's like a balloon that surrounds the joint, and it holds that fluid in there. And so obviously when your knee swells, that's what you're getting, that increase in fluid through the knee there. And the healthy hip joint, again, very similar. It's a ball and socket, but same sort of deal. It's got that cartilage lining it. It's also got a structure called a labrum, which basically lines that cartilage as well, helps in shock absorption and stability. And basically, osteoarthritis is a simple equation. When you have an imbalance of regeneration and degeneration, you get wear and tear. Okay, when that balance of regeneration and degeneration is in a line, then it's all good. And this is one of the factors that happens with developing osteoarthritis. If you're if you have an injury and you keep you don't get it treated properly, you keep moving on it, that balance of regeneration and degeneration gets skewed, and that leads to wear and tear. All right, osteoarthritis of the knee. So I'm sure you guys can relate to some of these. So you get obviously pain with weight bearing, a stiff and unstable leg, the knee gives out. Later in sort of the disease, you might get that knock knee or bow leg appearance, crunching and clicking noises, and reduced range of motion. Okay, and osteoarthritis of the knee doesn't. The latest guidelines is doctors shouldn't refer you for X-rays of the knee because they don't actually tell us anything. If you've got a stiff knee that swells, you've got an arthritic knee. So it's a waste of time and a waste of radiation on your body to get an X-ray of your knee. It's just it's one of those common symptoms. Arthritis of the hip, same thing, pain with weight bearing, reduced range of motion. Most commonly I find people complain of pain inside the groin there, but you can get it, on the outer part of the hip or the inner part of the thigh, and even above or inside the knee. So, and obviously, a lot of people have both of them at the same time, hip and knee OA. Hand, I said I'm not going to talk about today. Risk factors. All right, so in physio we call it, we divide risk factors into modifiable risk factors and non-modifiable. And the modifiable ones are the ones we're really interested in because we can't change the other ones, but these are the ones we can change. Firstly is joint injury. Okay, so if you've had a major knee injury when you were younger, it's firstly the impact of the injury, but then often the fact that it's not managed properly afterwards that sets you up for osteoarthritis. And we're seeing that unfortunately more and more. So more kids are having serious knee injuries, which is, so as I said, this stuff in 20, 30 years time, it's if we don't address it as a society, then it's going to get worse. Joint overload, again, that can be being overweight, doing the wrong type of exercise or doing too much of that type of exercise. But then the flip side of that is physical inactivity as well. As I said, if you don't move, you are more likely to get osteoarthritis. There's just a very interesting study just come out that basically people that run marathons are less likely to get osteoarthritis to their knee than people that walk for short amounts during the day. Okay, so previously, the theory was, if you run heaps and run and run and run, you'll wear out your joints, and that's now being dispelled. So the more you exercise, as long as it's the correct form of exercise, the less likely you'll have arthritis during your life. Yeah, of course, yeah. So, but again, the study compared, fit runners and fit walkers. You know what I mean? So they try to take out those variables, but absolutely, it's a big part of if you run, you're generally healthy, you're not overweight, so there's less loading on the joint. Yeah. But again, it's one of those myths that activity or overactivity equals wear and tear. Okay. And these are the non-modifiable. So age, obviously, as you get older, you're more likely to get osteoarthritis. Sex, so different forms of arthritis have different risk factors for women, and hereditary, and that's a big one. So generally, if your mum or dad had back arthritis or knee arthritis or hip arthritis, certainly you're more risky of getting it. There's that genetic code that's built into all of us, good things and bad things. So, alrighty, how's osteoarthritis diagnosed? This is the one we're trying to change, X-rays. There's a statistic that 20% of people that attend to a GP with knee osteoarthritis are referred for an X-ray. At the moment, only 2% are referred for physio or exercise. Okay? The X-ray tells us nothing that we don't already know. All the X-ray does is it more likely leads you down a path of having surgery.
The X-ray can't speak for others.
Yep.
The X-ray can be shown bone on bone.
Yep.
So surely that must influence the type of treatment.
So again, I hope to dispel that. So the relationship between what you see on X-ray and your symptoms is actually very, very poor. Yeah. So we could take an X-ray of 100 people of your age, and a lot of them may have bone-on-bone arthritis, but have very little pain.
Yeah, but if you have pain, of course it's bone-on-bone.
Yep.
Treat differently from pain and not bone.
Again, I'm not saying it doesn't help, but put it this way: if you went to a doctor and he X-rayed your knee and it was bone-on-bone arthritis, he would most likely say to you, the only thing that can fix this is a knee replacement. Yeah. Don't worry about exercise. Don't worry about losing weight. It's too far gone. Go see a surgeon. And the last session we just had, one of the ladies there, we just had a GLAD session then that just finished. She had, again, severe arthritis on the waiting list for a knee replacement. She's now cancelled that knee replacement. But she actually went to her doctor and said, this is great, this is working. And he said to her, let's still go ahead with the knee replacement. So, the message is not out there in terms of even the medical field. And knee replacements are great, operations are great, but they should be the last thing considered if everything else is kind of not working. Or if you're going to have a knee replacement, at least do some strengthening, lose some weight, they have a better outcome from it. Yeah. So X-rays are valid, but only if they're in conjunction with a rehab program or a weight loss program or something like that. And at the moment, in terms of as a society, we're seeing a lot of imaging and not much preventative or rehabilitative programs. So. Symptoms. So symptoms develop slowly. You have a feeling of instability or giving way, stiffness, reduced range of motion, pain on weight bearing, pain at rest, and red hot and swollen joints. We've already gone over those. And these are some of the kind of functional problems you guys might see. Yeah, yeah, putting on socks and shoes. Yeah, yeah, yeah. And and I dare say a lot of you have stopped doing these things because of your pain. Some of them you may want to stop doing, but some of them, we want you to start back up again. Okay. And that's a big one. Fatigue. So pain wears you down, inflammation wears you down, and you therefore again less motivated to exercise. So it's not just pain; it's also these other symptoms like fatigue, loss of motivation, fear of moving that osteoarthritis has. All right, now we're getting on to the treatment. Good, bad, and the ugly. So this is basically the osteoarthritis treatment pyramids. And this comes from the Australian College of General Practitioners. So basically what they're saying is that everyone with osteoarthritis should have education, exercise, and weight control. Okay? Some people with osteoarthritis should have painkillers, aids, passive treatments, and few people should have surgery. And certainly no one should skip straight to surgery without trying education. Because as I said, one, you might avoid surgery, but B, you're going to have a far better outcome from that surgery. And it doesn't matter if it's bone on bone or how bad it is. So I said that's the message we're trying to take out there to the GPs, and I've been visiting a lot of GPs, and I said it's just going to take time for that to kind of change, but this is what Medicare is going to, what health funds are going to, because it saves a lot of money as well. That's what they're really interested in. A surgery is very, very expensive. Painkillers are very, very expensive, and you take them all day, every day. Programs like these are very, very cost effective. And this is basically what the GLAD program does well, which is education, exercise, and weight loss. So we have 2 of these education sessions, where, as I said, the whole aim of it is to get you to understand what your condition is and try and get you to take away that fear of moving and to get you exercising again, and then teaching you the right form of exercise to do and the right dose of exercise to do. But think of it like exercise, like a medicine. It's fantastic if you take the right medicine and take the right dose. If you take the wrong medicine and take the wrong dose, it doesn't work, or it might even make you worse. And that's the problem with people with arthritis with exercise. Someone might have told them, oh, you've got to move, and they've gone out there and all of a sudden started walking 10 kilometres or going to the gym and doing squats and all these sorts of things. You've got to do the right type of exercise. And that's what this program does beautifully. And again, going back to that slide, why do we need to exercise? So cartilage needs appropriate load for it to be healthy. It improves joint range of motion, and it improves stability and function. Helps you move better and gives you more confidence. So I said that's the key thing with this first session is if you can understand that and you can believe in that, then it makes a big difference. So, and again, that's very, very. There's a real kind of window of good load. So you don't want too little, you don't want too much. There's that real golden zone in the middle there, which will teach you in the next lecture what that is. And if you can, and whether you do this program or don't do this program, it doesn't matter. if you can remember with whatever form of exercise you do to follow those principles and come up with a sort of optimal amount of loading, then you're going to go a long way to making your symptoms better. And everyone's different, you know. Obviously, the amount of load a 35-year-old person with, you know, early onset knee arthritis does to a 75-year-old person that's quite sedentary is going to be different. But the guidelines are the same, and as long as you follow those guidelines, it works really well. Okay, so additional treatments, medications. So obviously anti-inflammatories, painkillers, corticosteroid injections, and glucosamine. There's no evidence to suggest that it works. You know, you can take a, yeah. Yeah, no, you know, there's very little evidence suggests it does anything at all. So the recommendation is no. Yeah. You'll get some people that say it can help them, and that's fine. There's no harm in it, but it's there's absolutely no evidence to suggest it works. Yeah. And then additional stuff like foot support and bandaging, mobilising, walking aids, hot cold packs, TENS, acupuncture. Surgery. So this is the big one. Has anyone ever had an arthroscopy on their hip or knee? Yeah. How long ago was that? Okay. Yep. Okay. Yeah, the surgery. Yeah. Correct. Yeah. So basically, you know, there is no difference. So they did a big study where they compared people that had knee surgery, where they went in there and cleaned everything out and fixed everything up, to people that just went in there and came straight back out, and there was no difference in their outcomes. And you know, for arthroscopic surgery, the side effects are rare, but at the end of the day, it is surgery. It is invasive, and the osteoarthritis guidelines around the world do not recommend surgery. If you're in a private health fund, they generally won't pay for an arthroscope on your knee for osteoarthritis. Yeah, so if you've got a torn meniscus where there's your knee is locking and it's an acute injury, different ball game. But if you've just got a degenerative knee, yeah, and you know, to be cleaned up, again, yeah, there's no evidence to suggest it works. And again, that's only in the last few years, really. You know, still, you know, 6-7 years ago, we used to see, you know, arthroscope after arthroscope coming into the clinic here post-surgery. You just don't see that many of them these days. Total joint replacement. So artificial knee. Has anyone had a hip replacement or knee replacement here? No? Okay. So as I said, it really is the end of the road. Okay, so it's when everything else has not worked, when the pain is really stopping you from, you know, doing anything, moving, and it's a very, very effective surgery. You know, obviously it takes the pain away. There is a small percentage of people that do have, you know, moderate to significant complications from it. So it still is surgery that's best, you know, delayed or avoided. Yeah, it's generally a bit better these days. Depends on what you do with it, you know, but it's generally a bit longer than that these days. And again, you know, with the sort of changing of the tide, people will have them later in life now, you know, so yeah, so you're not going to get your 40-year-old guys having knee replacements and 50-year-old. So as I said, it really is the end of the treatment spectrum. Brilliant operation, but it is a big operation. You know, it takes a long time to get over. So you've really got to really need it. So this is basically a graph of the effectiveness of first line of treatments. So basically, this is the reduction in pain and improvement of function with these different treatments. So you can see there, you know, the big ones are exercise therapy. Okay, it's by far the most effective treatment for osteoarthritis, but it's by far the most least prescribed form of treatment. Whereas, you know, painkillers, anti-inflammatories, glucosamine, all this stuff is still routinely taken. The one thing that is proven to work best, unfortunately, is the one thing that's getting prescribed. And in the GLAD program, which is what we're talking about today, so 17,000 people have done this program in Europe, okay? And out of that 17,000 people, they had an average reduction in their pain by 32%. So it's pretty significant. And out of those 17,000 people that, of the people that were in a queue for a hip or knee replacement, 73% of those people delayed or avoided that surgery. Okay, so pretty amazing results. You know, drug companies certainly can't achieve those sort of results with painkillers and those sort of things. So, and this is now, the GLAD program's just slowly started filtering to Australia. We're certainly one of the first clinics to take it on. It's big in Europe, big in Canada, and now it's filtering here. It'll just, you know, eventually filter through the world, because as I said, basically it's more cost effective and it's more effective. America's a bit slower behind because they're very sort of surgery happy over there. So yeah. Now that basically wraps up the talk today about, so the first of the talks. I hope you guys kind of got a lot out of it. So the next session, basically, we go over, you know, the prescription of exercise. Okay, so why, you know, what some of the exercises you should be doing, how much you should be doing, and also how much to self-manage your arthritis. So how to self-manage your arthritis. So difficulties you may experience, what to do if it flares up, your activities of daily living, and coping strategies. But the point of this one today is for you guys to understand that you have to move and you have to exercise for this to get better. And then the next one is the kind of the how to do that sort of thing. Okay. So I'm just going to talk about the actual structure of the GLAD program. So as I said, the GLAD is basically a program where you get 2 education sessions, and then you're recommended to do 2 one-on-one sessions. There's an assessment at the start. So what we do is we get you in here as a one-on-one. We talk about your goals. We measure your weight. We do a couple of functional tests. So we do what's called a sit to stand test. So we measure how many times you can sit up and down in 45 seconds. We do what's called a timed 40-meter walk test. And then basically, then you do the program. At the end, we get you back in and we retest those measurements. And if you do go on the program, you also go on what's called a GLAD database. So there's an online database where we enter those results, providing, you know, you give us permission to, and that's how they get their data. So it's all objective. You know, we measure before and after, but as I said, even the people, we've only sort of been doing this for a couple of months now, and you know, we're having some really fantastic results. You know, just finished with a couple of ladies there, and I said one lady is, you know, put off her knee replacement, and the other lady, you know, is still going to go ahead with it, but you know, she's excited about it now. But the other thing about GLAD is that it has been shown that if you do have if you are going to have a knee replacement, you have a far better outcome if you do a program like this. And the program can be done at home. It doesn't have to be done in here. But what does need to be done is that initial session, because if you're going to do it at home, then we give you the exercises. But like anything, you've got to do them. And the benefit of doing it in here is that we have Jacko back there, is watching on.
Watch you do it.
They watch you do it,
I'm sure you do it.
I can't cheat.
and they correct your movement. So say if I get you going home and doing some lunges, you may do this, okay? Whereas, Jackson or myself or whoever will be correcting your knee, making sure you're moving properly, answering your questions. So, obviously it's much more preferable for you to do it, at least some part of it supervised. Some of our clients just do it once a week here, then they do a session at home. That's totally fine. You can do it once every month. You can do it not at all, but as I said, you will get a better outcome. You can do it at CABA, but you'd have to do it a slightly different way. So you'd have to do a GLAD program. Are you talking with Derek?
Yeah, I was just thinking when I take Derek up to his.
Oh, that's fine. Yeah, we can sort that out. Yeah, because he does one-on-one, doesn't he? With Joel?
With Joel.
Yeah, that's fine. That's no problem at all. Yeah.
It doesn't matter. It's just that all the copies is fine.
Yeah. So what we've actually done is so previously we've had 2 GLAD sessions, 12 o'clock Monday, 12 o'clock Friday. The problem with that is everyone's got busy lives and things on. It's hard for some people to get to those 2 sessions. So we do give you the option to do the GLAD program in any one of our classes. So you're doing GLAD exercises. Yeah, still taught by a physio. The only thing is you're not with a bunch of other people. Yeah, so there's a bit of that kind of bit of support. You know what I mean? You're sort of feeding off it. Competition, yeah, maybe, yeah. But I said it's really powerful. I think if you come into a program like this and you speak to someone, and it's all good me getting up here and spruiking something, but if you get in there and you speak to someone who's like that lady who's like I said to her, can you tell everyone on the way out how good you're doing? If you hear it from the horse's mouth, from someone who's done the program, started off, with the same fears and, so everyone we got in here, it takes a few sessions. They're like, oh,
I haven't got problems doing the exercise.
Yep.
I'm an asthmatic.
Yep.
And that's a bit of my problem.
Yep.
Is being able to breathe.
Yep. Again, there's different levels of the exercises. So there's not a big cardio component to it. Okay, so it's not like we're getting you to jump and run and things like that. It's all very flexible. So for you, we'd probably say the warm-up part, which is generally bike riding, we just probably tone that down a little bit. It's all Jacko sort of has done more than me, but I'm sure you'll agree. It's quite easy to
Well, I started when Derek goes to Joel. I walk.
Good on the treadmill. Yep, or out and about.
No,
On the treadmill. Yep, great. Yep.
But it's just a straight walk. It's not a program.
Yep. Yeah, no, I'll have a chat to Joel. Honestly, that's not a problem at all. We can. Yeah, that's absolutely fine. So the options are there. So previously we sort of made everyone go into those 2 sessions, but as I said, that's proven difficult for some people just because they've got things on and there's only 2 sessions available a week. So we've just made the decision that you can still do a GLAD program in a clinical exercise class, exactly the same amount of people, but you'll be doing GLAD exercises. Which is
2 sets of exercise, 2 days have the same set of exercises, so it's just duplicate.
Yeah.
So you could do one here and one home.
Of course. Yep.
And just interested in the statistics here, the benefit last 12 months on the assumption you stop doing it after 6 weeks.
So that was based on people doing the program for 3 months. Okay. So what they did is they did a study where they had people do the GLAD program for 3 months, and then they had people have a cortisone injection, and they had people that did a couple of other things. One was like called Synvisc, which is like an injection that stimulates fluid. And basically, if you look at cortisone and those other things, the effect stops after 3 months, whereas the benefits from the strengthening last 12 months, even if you don't keep it up. Yeah.
Normally, just after the 6 weeks,
You'd be crazy. Exactly. Yeah, you'd be crazy not to. But yes, the benefit, it is sustained benefit. It doesn't just stop the day you. Yeah. But it said that study, people didn't specifically keep up the program. They just did it for 3 months, stopped. At 12 months, they were still significantly better. Yeah.
Now, do we need to come to the next talk session as well?
So basically, what I do is I video each of these talk sessions. So if you can't come to it, we just email you a video of the next talk session.
You said something about next session is about hands.
No, sorry, I said we don't cover hand in this program.
We don't do that.
Yeah, GLAD is just hip and knee osteoarthritis, sorry, yeah. Hands are different kind of beast altogether, yeah.
They're my biggest problems.
Yeah. No, it's GLAD is basically just for hip and knee. Yeah. We cover hands in the education just because it's one of those things that goes commonly with hip and knee. So this is basically the a slideshow of what happens. So as I said, now generally with the GLAD program, what the ideal thing is that they say have the assessment with the clinician first. We've flipped that a little bit and given you the education first, sort of for the hope that you might see the benefit of it and want to book in for one of the assessments. Do we find out, are you eligible for the program? Pretty much everyone is. The only people that are not eligible is if you have something like fibromyalgia, like a specific pain condition where everywhere. Yeah. But it kind of clouds pain. So we use pain as a guide of how much load to put on your knee. If you've got a condition, a systemic condition that causes pain here, there, and everywhere, we're not going to know what the correct dose is. So that's pretty much it. Everyone else is, you don't have to be fit. You don't have to be. We can tailor it. And then obviously, so first session we've talked about today. Second session, which we're doing on Monday, said you can come to it or not come to it. If you don't, happy to email you a link to the education. And then basically it's the choice of you guys. So you can do then choice of class-based exercises. And so that class-based exercise is some slight cardio work on the bike or the treadmill to warm up. And then you do a set of what we call neuromuscular exercises. So basically it's teaching you to be able to control your knee or hip better when you're moving. So it's not moving incorrectly and you're not overloading the joint. We do some strengthening for the lower limb muscles. There's some core stability work to get your tummy muscles going better. And that takes about 50 to 55 minutes. Okay, so it's kind of like a little circuit you move around, and it ticks all those boxes. And I said everyone in that session will be at different levels, so it doesn't matter where you start. And I did exactly. You go up through the so we increase the resistance, we increase the stability requirements. And it's all based on you feeding back to us, during this program, during the session, and then after the session as well. You will need a couple of little exercise bands, which are $5. And then ideally as well, these little things you get from Bunnings are about again $5. It's like a furniture slider, so we use them to do some of the they sort of slide along the floor. It's not essential, but it would help. And that works fine. So you have these, Yep. Yeah, so basically I'll sort of cover this a bit more in the next one, but essentially what we're looking at is we don't want the symptoms to last more than 24 hours after your session. So the next, if you might, say if you get a tiny bit of pain after exercise for the first few classes, remember your knee hasn't done a lot. We want that to settle within 24 hours. Okay, so generally the next day you'd just do your normal activities, but really the key thing with osteoarthritis is regular loading. So you don't want to do this, you want to do that.
So if possible, every other day.
Yeah. So in terms of the strength exercises, 3 sessions a week is really fine. But on the other days, that's when you sort of might do your walking and something else. Yeah. But it's still loading, but you don't need to do 7s. Yeah, exactly. Yeah. So it works really well like that. So. And then, as I said, then we do, so preferably people come twice a week for 6 weeks. That's completely, as I said, flexible. I would suggest really thinking of it as a 12-week program. Because I think that's, if you have in your head, I'm going to do this for 3 months, you're going to get a lot more out of it, whether that's here or at home or whatever. I think they probably put 6 weeks down because it's, that's all right. I thought it was my phone. I think they put 6 weeks down because it's a bit less confronting to people, you know what I mean? Like, 6 weeks, I can do that. But really, I think, it needs to be a commitment of 3 months. Right? Yeah, so I'll go through that now. So basically, this is we sort of bundled everything up, okay? And this is what's called our GLAD package. And we did this basically to try and make it as cost effective as we can for you guys. But again, it's completely flexible. So in the GLAD pack, you get the 2 one-on-one sessions. You get the 2 education sessions, which you get anyway. And then you get 12 supervised exercise sessions over a minimum of 6-week period. You may choose to do it over 12 weeks. That's fine. Of course. Yeah. There's no expire on that. You can, but yeah, generally we like, it works best if you at least got a 6-week block, where I think you can get the idea, get the exercises. So say if you're going overseas on a cruise for a couple of weeks, if it's in 6 weeks' time, that's fine, because by then you'll know the exercises and you'll have that confidence. Yep. And that's normally $560. We give it to everyone for $440. And then we do have obviously if you sign up during one of the education sessions, we make it even cheaper, so it's $396.
So when you say today,
that's fine, yeah, that's fine. You go home and have a think about it, but as I said, we'd like to make some sort of motivation for people. Okay, that sounds good. I'm happy to sign up. Now, the other option is, if you, obviously, arthritis is a chronic condition. So the other option, which a lot of our clients do, is they use a Medicare referral from their doctor to cover the one-on-one sessions, which is absolutely fine as well. Okay. I can't stand here and say your GP will give you those. I'm not allowed to say that, but yeah. Yeah, exactly. Yeah. So, you may choose to, use your Medicare sessions for those. And then, just buy a small pack of the exercise sessions. It really is very, very flexible, but this is it all bundled together. And if you do all that, you've done the GLAD program, and, you'll get the benefits that people have done the GLAD program. It basically depends on how many you buy. So if you buy 10, the cost is $280. As you can see there, 12 for an extra $80, $90, you get 2 more sessions and 2 one-on-one sessions. Yeah.
So you do go to the doctor and get it on
Yep.
Do you have a charge on top of it?
No. No, that's yeah, those two are bulk billed. So I said, you know, a lot of people may choose just to do that and then buy a 10 pack. So buy what we call a GLAD 10 pack. Do that over, you know, 6 to 8 weeks. That's a great option as well. You can come casually, just do one class here and there if you want. You know, they're all great options. But I said, we're getting tested. Do you know how much it is, Jacko? A single class, casual? Yep, 35. Yeah, yeah. I mean, as I said, you know, I think the commitment is what works, you know, and that's why we've made it cheaper because if you buy a session here or there, look, there's a lot more variables. You know, I think, yeah, the people that have done really well, I think you'd agree, Jacko, are the ones that, you know, have done that in the first phase, have done that twice a week. Yeah. Because you know, you might do one session, you might be sore, you know, and oh, hang on, you know, if you're not due back for 2 weeks, you've been too scared to exercise. Whereas if you do that second session in a week, come in, we talk about it. Okay, what hurt during last session? You know, what do you think? Right, let's modify that, and then, you know, and then we're on our way. I said 1 hour. So I said that. Yeah, that's really really a summation of it. As I said, yeah, it's yeah, we you know, we've had a really good result with it. We're just trying to get the message out there. As I said, you know, if we just want to try and make it as flexible as possible, but as I said, you will get the most benefit by being under the eye of a physio. And the two ladies that are really probably our success stories so far, would you agree, are, you know, the ones that have kind of been really. Yeah. And it's a really good environment, you know, it's fun, you know, everyone chats and yeah, it's any questions, guys? Yeah. Yeah. So the big thing is, don't be scared to move. Pain doesn't equal harm. Okay. Exercising is not going to wear your knee or hip out further, providing you do the right exercise in the right amount. We do that a little bit. And certainly, yeah, we talk about, you know, the correct type of exercise, so strength exercises, neuromuscular exercises, the cardio exercise. You know, but the big thing is really the dosage, you know, to what to look out for. How much pain should you expect? How long should that last? What causes the pain? Again, I'm a believer if you can understand what causes it, then it makes it a lot easier to deal with. And you know, when you load any joints or muscle, you know, and stimulate it, it does hurt a little bit. But as long as then you give it time to settle, and it's not really overcooking it, it's a really good thing. Yeah. So I said, yeah, I'm happy to sort you out with.
Well, I was thinking if I did one session here.
Yeah.
And I can do a session down at the therapist.
Yep.
So it's only going once a week.
Yep. Oh, is he? Okay. Yep. Okay, perfect. Yeah, right. Yeah. Yeah, so you just buy a pack then, yeah, and we'll do that. That works out perfectly. Yeah. And yeah, and so if anyone else does have any questions about the price, or if you want to purchase the pack, as I said, don't let the fact that it's on Monday and Friday only put you off. We can work around that. And that's only a recent change we've made, just because, yeah, I know what it's like. Everyone's got busy lives and, you know, stuff on, but in saying that, we'd much rather see you in the GLA classes because it's just much easier to kind of manage, and I think you get a fair bit of support out of it.
So if you say
Yep.
your classes twice a week,
Yep.
and you get to do that, you just buy another
Correct.
package
Yep.
and then you
Continue as you want. Yep. And that's what we really encourage. So once you've got those benefits, so once you've improved your strength, improved your control, you know, you don't necessarily need to come twice a week. If you do it once a week, you know, and then supplement that with a session at home once a week, that's just going to keep that going. You know, but as I said, and as Jacko said, most people have done all the people who've done the program, they don't want that pain to come back. You know, they don't want to. You know, they might have started walking on the beach again. They don't want to stop walking on the beach again. It's you know, it's a small, you know, to do one class a week, it's a small investment to get it going. So, yeah. Thank you so much. All right, so everyone has a great weekend. Yeah, Helen's at the front desk if anyone wants to ask any questions about pricing. Yeah, and I might see some of you on Monday. Nice.
Yep.